This video takes a deeper dive into the use of IG therapy for PI by discussing diagnostic criteria and highlighting the recommended dosage criteria for a number of PI conditions. The American Academy of Allergy, Asthma, and Immunology has developed 8 guiding principles for effective use of IVIG for patients with primary immunodeficiency. These are indication, diagnoses, frequency of IVIG treatment, dose, IgG trough level, site of care, route of administration, product. You can learn more about these guiding principles and other valuable information in the American Academy of Allergy, Asthma, and Immunology's IVIG Toolkit, located at primaryimmune.org/insurers-payers. The most common antibody-deficient PI is common variable immune deficiency. The diagnostic criteria for CVID requires that a patient have at least one of the following: an increased susceptibility to infection, autoimmune disease, granulomatous disease, or an affected family member with an antibody deficiency. The patient must also have a marked decrease in serum IgG and IgA with or without low IgM, and a poor antibody response to vaccines or low switched memory B cells. Lastly, secondary causes of hypogammaglobulinemia must be excluded. Any coverage policy for IG replacement therapy for PI must include the criteria for the specific PI medical condition. If it is based upon recurrent infection, then first there must be a history of infections requiring multiple courses of antibiotic therapy, except for those who have the most profound antibody deficiency disorders. And second, there must be laboratory evidence of immunoglobulin deficiency. This may include agammaglobulinemia, where the total IgG is less than 200 milligrams per deciliter; persistent hypogammaglobulinemia, where the total IgG is less than 400 milligrams per deciliter, or at least 2 standard deviations below normal, based on age-appropriate values for serum IgG on at least 2 occasions; a lack of protective antibody titers to protein antigens, such as tetanus or diphtheria, measured before and again 4 to 6 weeks after immunization, and or an inadequate responsiveness at 4 weeks to Pneumovax 23 vaccine, as defined as having 50% or less serotypes, being protective or reflecting no less than 1.3 microgram per milliliter per serotype. If the baseline serotype-specific antibody level is already greater than or equal to 1.3 microgram per milliliter, then an adequate response is a 2-fold increase. Selective antibody deficiency, or SAD, in which patients have normal total IgG levels but impaired production of specific antibodies, including those with isolated deficient responses to numerous polysaccharide antigens following vaccination. Because SAD can present a diagnostic challenge, immunoglobulin replacement therapy should be provided when there is well-documented severe polysaccharide non-responsiveness and evidence of recurrent infections, with a proven requirement for antibiotic therapy. In summary, immunoglobulin replacement therapy is required in patients with certain PI diagnoses characterized by absent or deficient antibody production. The treatment regimens should be individualized for each patient.